Welcome to the BMJ podcast. I'm Duncan Jarvis, standing in for Cameron Abbasi. In the UK, summer seems to have come to an abrupt end, and so have the Olympics. But what happens to all of those athletes from here? Jonathan Finnoff is the Chief Medical Officer of the US Olympic and Paralympic Committee and joins us to talk about athlete healthcare outside of the Games.
It is a marketing deal where we exchange healthcare, where we send our athletes to them for healthcare, and they get marketing rights to be an affiliated partner with the US Olympic and Paralympic Committee.
But first, the news that GPs are carrying out collective action has spooked the healthcare system in the UK. GP practices are run as small businesses which contract with the government to provide services. A recent vote organised by the BMA of GP partners had a 98.3% vote for collective action. Now that could mean GPs seeing no more than 25 patients a day or refusing to share patients' data unless it's in the best interests of the patient, and potentially even switching off NHS software that tries to cut prescribing costs. The root of all of this disquiet is the imposition of the terms of the contract for GPs, including below inflationary increase in funding, which has led to some practices being forced to close. Gareth Yakibuchi is the BMJ's assistant news editor, and he spoke to Katie Bramall-Stainer, the chair of the BMA's GP committee, about their concerns.
What do you think has led to this point, really, for the profession, to the point where they're, have voted pretty overwhelmingly in this ballot for action? But what do you think are the kind of main factors or the key factors that have led to this point?
Of course, I think it's been challenging for us in terms of the optics, because we've had the general election and then we've seen the juniors, well, in terms of the resident doctor and negotiators, take a deal to their membership. And then it looks as if we're suddenly coming in on the coattails of all of that, having a bit of a go, when in actual fact, we've been in pretty dire straits for an extremely long time. I would say the past 8 years have been perilous. We've lost over 1,300 practices in the past decade. If you go all the way back to 2010, we've lost over 2,000. We've lost the equivalent of 2,000 full-time GPs, but actually you could argue, if you add up everybody who's gained a CCT and joined the performers list, we've lost far, far more than that. So the profession itself is collapsing. There's no question about it. And if general practice is the bedrock of the NHS, then the NHS is collapsing with it as well. What's really interesting with some of the media headlines has been how we could bring the NHS to a standstill by merely following what we're contracted to do. And I find that really interesting, because it perhaps then suggests that we maybe deserve to be resourced for all that additional work that we do, that we deliver to the NHS, that keeps it going. Because if people don't want to buy what we can offer, well, then let's have an honest conversation about it. We're hearing great things from the government about what they want to do, and that sounds wonderful, but we're hearing the actions say something else from NHS and the Department of Health. And so what's really important is we understand, really, I need candour and transparency and honesty in order to be able to move this forwards. So it's crunch time. And I think if you ask any member of the public, their perception, their experience of their local family doctor service, everyone's got something to say, and it's not great because they've lost their doctor or their service has changed completely. And the kind of service we want to give and the kind of services patients want to receive are the same thing. So actually there's an awful lot more, I think, that unites family doctors, their practice teams and patients out there than perhaps we realise. We've written a heads of terms as to what do we need, what longer term. So what do we need in 25 and 26? What do we want longer term? Almost like a family doctor charter 60 years on from the last one. And that we've tried to tailor around some of Labour's election manifesto commitments.
Yeah. And have you
the
presented it to them?
Yeah, we have.
Yeah.
Absolutely. Yeah, we have. And West Streeting said, well, none of this looks unreasonable. We're like, great. So let's progress. And I think West Streeting, you know, as is his right, had a hope that we might avert action on the premise of trust, that he would then try and take those forwards. But unfortunately, as we said, whilst we've still got practices closing and we've still hemorrhaging GPs from the workforce, we have no choice but to take this action, because this action is protective to prevent further practice closures and prevent further attrition of the workforce. It's also completely legally permissible. And we've got an enormous mandate, 98.3% from partners who are really conflict averse, who never want to rock the boat. And we can't really ignore the fact that once you tell your workforce you've lost almost 2,000 practices, that's almost 1 in 4 practices have been lost, and thousands of GPs. At what point do you go, well, hang on, is someone going to do something about this? And phase 1 was deliberate, that it would feel safe, it would be easy, it would be sustainable, to allow practice, to remind practices of their autonomy and what was in their contract and what is permissible for them to do, to take their own steps to protect their own staff and their own workforce. But phase 2, that's the one I'd be really worried about in the Department of Health's shoes, because that's where you might be looking at salaried GPs or other practice staff. We've mentioned nurses, there could be others, looking to withdraw their services because they are employees and they could strike if they decided to hold an indicative ballot and then a formal ballot and then reach the requisite numbers. They absolutely could do that. And if they timed it together, well, then in many cases across the country, I could envisage some surgeries, some practices not even being able to open. So that's something that we really want to avoid, especially going into the winter. So I think this could be, and I want it to be, a real win-win for the new government and also for general practice as a profession. But at the moment, I'm a pragmatist, and I represent a profession that doesn't like conflict and always wants to find an answer, but has been trying to find an answer for so long. It has chosen not to look at the facts in the face. And the facts are that the profession is being constructively dismissed, and not for any good evidence-based reform either. So I think we do need to fight to protect general practice. The good news we have is that the British Social Attitude Survey from this year, 91% of the public want to keep the NHS free at the point of service. And so that's great, because if you want to keep it free at the point of service, you've got to have a really good gatekeeper. But we've diminished the gatekeeper. And if you break the gatekeeper, you break the NHS. So we've got a really good reason to try and turn this around. And it absolutely is salvageable. But the longer it's left, the harder it will be.
Physician associates is a real sort of hot button subject at the moment. And I think the BMA has just published new guidance on PAs in general practice as well. So I just wanted to ask what sort of the appropriate role is for physician associates to be playing in general practice.
I think everybody recognises this has become quite a polarised debate, especially on social media. I think it's very important, and the reason why we've produced separate guidance is because there was an awful lot of feedback on the back of the BMA's Medical Associate Professionals Guidance, which is relevant to all specialties. There was a lot of feedback that actually, what about general practice? Because it is different. The employment model is different, the presentation is different, the differentiation is different. I struggle to really understand how and where PAs fit in an undifferentiated generalist model. Yeah. I think if there is an argument, it is where you have already a degree of innate triage, be it in a respiratory hub or in more greater detailed algorithms of care. I can see better an argument for PAs in a hospital-based model, which is where they have got a lot more evidence and years of data and longitudinal studies in North America, for example. I'm very conscious with my LMC hat on and sitting on the Performers Advisory Group in NHS England for our patch for GPs who are going through performance issues, that when mistakes are made, or there's poor documentation or poor communication, or patients feel they've not had the full truth, that for a PA who's employed, the responsibility sits with the employer and it sits with that GP.
Yeah.
So it's really important that GPs understand that getting in a PA isn't going to change their workload enormously. I would much rather they invest in their GP workforce, their practice nurse workforce, clinical pharmacists or physios or whatever, paramedics if need be for, home visits and the rest of it, or urgent care presentations. I find it harder to understand the benefit of where PAs can sit at scale. That's not to say you can't have horses for courses. You might have some very large, sophisticated organisations that have got really good supervisory elements embedded into their governance, and that's great. But I'm here to represent all practices, big and small, simple and complicated. And as a one size fits all, I struggle to see how that's really going to be particularly effective.
Mm-hmm.
And I think this plays into a bigger agenda, which we're probably going to see over the course of the next few years play out. I keep hearing questions which don't just suddenly spontaneously generate out of the primordial soup. They've been placed and thought and considered, which are, why does it take so long to qualify as a doctor? Why does it take so long to qualify as a consultant? Why does a dermatologist take 13 years to qualify? Why can't we do it quicker? And there's this idea and suggestion that we can do it quicker. And I think that needs a more considered approach rather than, okay, let's just give somebody who's got a 2-year course. Because general practice is the easiest specialty to do harm. It's the easiest specialty to do badly. I'd say it's one of the hardest to do really well. And that's quite a famous quote from David Haslam, a former chair of the RCGP Council back when I was a newly qualified GP. But I stand by it. I think it's really challenging. And I think a lot of people think general practice looks easy. How hard can it be? It's coughs and colds, right? And it's only really when they're presented with the complexities that they realise this is perhaps a bit more to this than meets the eye. And I think the kind of trend I've been trying to get GPs to understand on the roadshows and the webinars, all of us have, is that it's one thing to look like you're gliding over the water, but if you're paddling furiously underneath, maybe you should be bringing more patients in face-to-face so everyone can see how busy the waiting rooms are. Maybe when you're triaging hundreds of patients, that needs to be really visible in terms of what you're doing, because you're making it look really easy. Everyone thinks they can have a go at your job, and they try. Turns out they can't. Turns out, yeah, you did need those 10 years of training, at least.
And Gareth's full interview with Katie Bramall-Stainer is available on bmj.com. And there you can also keep up to date on the latest that's happening with the industrial action. It's already changed since we did this interview, and I'm sure it will change again in the near future. So check out bmj.com for the latest news. The Olympic and Paralympic Games have finished, and all of the athletes and their support staff are returning to their regular lives. But what does that mean for their healthcare? Many athletes, particularly Paralympians, will have ongoing medical needs. Jonathan Finnoff is the Chief Medical Officer of the US Olympic and Paralympic Committee and joins us to explain healthcare at the Games and beyond.
We bring over 200 medical personnel to the Summer Olympic Games. Over 40 of them are physicians, and we bring athletic trainers, physical therapists, chiropractors, massage therapists, and psychological services providers. So we actually have a fairly robust system that we can do most things for our athletes. But when it goes above what we can do, then it goes to the polyclinic. When it goes above what the polyclinic can do, then it goes to the hospital.
I didn't imagine your team would be just that large.
Yeah, I mean, if you think about it really quick, Duncan, I mean, we have nearly 600 athletes that we are taking care of, but we also have to take care of all the support staff. And that puts us up around the 5,000 person realm. And so we have to have a fairly robust medical team to take care of all of the different medical problems that can occur within this huge delegation. So it's not just the athletes, even though those are the primary focus. You might have somebody who has a heart attack or a stroke or a bleeding ulcer or COVID or whatever, and you have to be prepared to take care of all of those things, allergic reactions in kids. that are part of the delegation. Athletes have families that come with them, and so it's just it's pretty amazing all the different things that we end up taking care of. We had over 4,000 medical encounters within the U.S. medical team during the Olympic Games.
Now, one of your athletes, Ariana Ramsey, who plays for the women's rugby team, had a moment during the games where she went viral for a TikTok she posted.
Okay, y'all, so not only in the village do we have free food, but we have free dental, free health care. I literally just got a pap smear for free, and I have a dentist appointment, and I exam next week. Like, what?
And that TikTok made me think about the provision of kind of everyday healthcare for athletes. You're obviously looking after their kind of sporting health, but people have other things going on. And presumably there are some of your athletes who are earning mega bucks and can afford insurance, but others might be struggling a little bit with that. And so it made me wonder, what's the outer edge of the care that the sort of Olympics provide?
Our athletes, while people see some of our very, very famous athletes who make millions and millions of dollars, just like the football players over in Europe, various professional athletes make a lot of money. But the average income for an Olympic and Paralympic athlete in the United States is less than $50,000, which is, it's not bad, but it's not much. And a lot of them have other jobs in order to support their sports habit, their sports dreams. The top tier athletes, though, in the United States, and there are roughly 1,500 people that qualify within that top tier, they receive elite athlete health insurance from the US Olympic and Paralympic Committee. And that is a very good private insurance program, and we are self-insured, so we fully fund that insurance program. On top of that, we have a medical assistance fund and a mental health assistance fund. So when somebody has out-of-pocket expenses, it reimburses them for those out-of-pocket expenses because there are co-pays and other things that are associated with it. But the elite athlete health insurance allows them to access health care at any hospital or with any provider in the country. However, we also have medical network partners, and these are groups that have, it is a marketing deal where we exchange healthcare, where we send our athletes to them for healthcare, and they get marketing rights to be an affiliated partner with the US Olympic and Paralympic Committee. But it allows us to access world-class comprehensive care for our athletes at those locations. And so we will fly athletes out there if they don't live in the location, put them up, feed them, and get them all of the appointments that they need, all of the imaging they need, the surgery that they need, and all of that is free for the athletes. And then if they have to go back to their own home location, then they can use their elite athlete health insurance for their ongoing care and their follow-up care from there. We also have 3 medical clinics located within the Olympic and Paralympic training centers. So one in Chula Vista, California, one in Lake Placid, New York, and one in Colorado Springs, where we provide predominantly rehabilitation services, but some medical services on top of that. But athletes can come and get evaluated, and then also longer-term rehabilitation care for injuries that require more sophisticated and prolonged care for their injuries. And we have our psychological services team that help people from a mental health and a mental performance standpoint throughout their careers. And that's including the ramp up to the games, people who don't make it to the games, and helping them with that transition, getting them through the games, and then also the post-games blues, which are very real, whether you're retiring after the games and have achieved your goals, or whether you're going on with your career. It's like this big thing and then it's over. And then people are thinking about, well, what's the next thing that I need to do within my life? And so we have a very robust psychological services program. And then we have a transition program right now. And I'd say that the area that is a limitation that we need to work on is what we do after somebody retires. because we don't have a lot of services after they leave the Olympic and Paralympic movement. And that's something that we need to work on down the road.
And I imagine that must be particularly tough for a Paralympian who perhaps has a lot of help and support during the Games or their time as an Olympian. But, those needs will go on in the future as well.
Absolutely. Absolutely. The Paralympic athletes they're a unique set of athletes. They are incredibly resilient, and most of them, they're Paralympians because they have an underlying medical condition or impairment, whether that's loss of a limb or spinal cord injury or neurologic disorder or visual impairment, et cetera, et cetera. They have these things that will be with them for their entire lives. And some of them come with a lot of comorbidities. For instance, if you have a spinal cord injury, say a higher spinal cord injury, then the bones below that level tend to get thinner because they're not getting the same stress. And so they tend to break easier. If you're insensate below the level of your injury, then you tend to be more prone to getting decubitus ulceration, where the skin breaks down and you can get really bad decubitus ulcers and infections, and those can be life-threatening. Your bladders and your bladder and bowels don't work the same, and so you have to be on bowel and bladder programs in order to have normal function within those areas, but it predisposes to developing problems with urinary tract infections, getting renal insufficiency. If you have a noxious stimulus below the level of the spinal cord injury, and the spinal cord injury is above the 6th thoracic level, then you can have a thing called autonomic dysreflexia, where your blood pressure goes a little crazy because of this noxious stimulus, and it can be life-threatening. So you just have all of these different factors that go into not only taking care of the Paralympic athlete in the lead up and through the Games, but as you said, really throughout their lives.
And for some athletes, this might be their last Games because that's been planned. They're at an age that they want to retire. But for others, after this Games, they might have medical issues that require retirement. Is that a conversation that you have to have with athletes? It must be a hard one.
Absolutely. I mean, the conversation of retirement due to a medical condition is one it's a hard conversation to have. Sometimes it's obvious. It's obvious to the athlete. It's obvious to you, and they're just looking more for confirmation. But sometimes it's something that people are not ready to accept, and they really struggle with. I strongly believe in shared decision making. So really talking to the athlete about what are the risks and benefits with different choices, what are the treatment options, what are the long-term outcomes, and really trying to educate them so that they can make the wisest decision possible. And the truth of the matter is that most athletes, in my experience, after long conversations with them, their family members, if they want to involve them, entourage, counselors, people who they listen to. Often athletes make the right decision, and you don't actually have to medically disqualify them. They make the right choice based on their health. But sometimes, athletes don't, and depending on the risk associated with that to them and to others, sometimes you do have to actually medically disqualify that individual against their will. They would prefer not to have that medical disqualification. But that's, I think, very, very rare. It's uncommon.
And presumably that's where some of the psychological services that you mentioned might be
absolutely
needed.
Absolutely. I mean, the psychological services team, just a little bit on that topic. So when I arrived at the US Olympic and Paralympic Committee, just over the history of Olympic and Paralympic sport within the United States, and again, this is not unique to the United States, this happens around the world, there have been some really tragic mental health occurrences with some suicides or attempted suicides, and then also just prolonged depression and real struggles, some of them very public and some of them not as public. When I arrived, the US Olympic and Paralympic Committee already had recognized that this is an area that they wanted to build more infrastructure around. And since I have been within my position, we've really worked to create a robust psychological services team that has numerous different resources for athletes, as well as trying to destigmatize mental health and help them to feel more accepting of seeking help for mental health conditions. So some of the things that we've done, number one, we do education. We do mental health first aid that's offered for free to any athlete or entourage, coaches, family members, and so on, so that they can recognize mental health conditions and then also intervene if they happen to be the person who is there when somebody is in a mental health crisis or mental health emergency. We offer different apps and self-help programs where people can monitor and do things that are mindful exercises to try to help themselves, prevent any mental health problems, but also monitor for they're starting to develop some symptoms and suggesting self-help interventions, as well as notifying US Olympic and Paralympic Committee psychological services providers to be able to reach out to that individual and offer them, help. We have our elite athlete health insurance covers 100% of any mental health cost associated with counseling services. We have internal providers who the athletes can seek. We have a list that is externally facing that anybody in the world can go to the US Olympic and Paralympic Committee's website, and it has a list of mental health providers around the country in the United States and their subspecialties and their people that are vetted and that we recommend, so that athletes or anybody else who would prefer to not come to our providers but would like to do something on their own, they're here people that we recommend. So it gives people privacy and the ability to find that. We have virtual services. We provide psychological services providers who go to the games. And we do screening for any athlete that is going to a major games with us. We do the sport mental health assessment tool, and anybody who has a flag of concern related to a number of different mental health realms, they get a call from one of our psychological services providers to kind of follow up on it and say, hey, we found this on this screen. Can we talk about this and determine what resources that individual needs? So we really take this very seriously and have developed a very robust psychological services system for our athletes.
That's it for this episode. Cameron will be back soon with more discussion from the world of medicine. Subscribe so you don't miss out on that. I'm Duncan Jarvis. Thanks for listening.